incoming, but we'll just give it a minute or so. Dr. Brown, is everybody that you're expecting here? Or?
In about 30 seconds.
All right.
Does that stand for employees?
I don't know, I thought it did, but
Employee, spouse,
I
employee?
thought it did, but it didn't really make sense. Why didn't they just, okay, this is employee, this is employee. Okay, that's what it is.
There's always been a coming
This is
in.
employee.
So
And they highlighted
They
that.
can, we don't.
That it's employer and employee.
we don't decide which of
Which
the
one
jobs.
they got, okay.
All right, so I'm going to start. How are you? Good. Good evening, everybody. We have an important discussion and conversation tonight. We wanted to make sure that this would happen in a public forum as a work session. We have many guests, and I'm sure that they will be introduced to us. I hear an echo, so I'll put it there for now. And so pretty much kind of the goal of this session is a lot of information has just been brought to us. It's to inform and to get from us direction is what I was told. Not to decide tonight, but to get a clear sense from the board as to where are we leaning, what is it that we want to see and consider as far as benefits, and also to educate ourselves, obviously to inform and educate the public, and then more importantly to ensure that we have the right information as we are approached by the people most impacted through this, which are our faculty and staff. And so without further ado, I'll pass it on to the board. I'll be keeping to Dr. Brown. I'll be keeping an eye if there's comments or questions. Though we'll kind of play it by ear if there's a quick comment or anything else that you'll need. So.
All right, thank you, Chairman Perez and members of the board. Thank you for taking time this afternoon to discuss our benefits packages here for Hamilton County Schools. We have lots of guests with us. I'm just going to briefly mention their name. They can introduce themselves. We're going to tag team this presentation for you. But we have members of RVA with us, Brent Wick, Katie Petty, and David Kinsler. And then, of course, we have our one of our favorite pharmacists from Ed Health Pharmacy, Josh Sanders, with us as well. And then Penny, Mary Ellen, and all will be tag teaming this presentation to give you all the information. But I want to start off with, clearly our strategic plan. We think about our just cause, right? All children thrive, experience a future without limits. It really starts, if we want to do that, we've got to have great employees, right? Great teachers, great leaders. And part of the strategic plan, every employee value, benefits follow every employee value. We feel here in Hamilton County that we have a great benefits plan. We want to continue that, but we want to make sure that we're doing it the right way and that we can continue having a great plan for years to come. So I want to jump right in and just, and I know in front of you, I believe you have a brochure our benefits overview packet there from 23. But I just want to remind the board of what we offer currently. You can see that we actually offer 3 medical plans. That's the Blue Cross Blue Shield, our PPO, 2 options for Cigna, the HMO, as well as the high deductible plan. We have 2 dental plans. If you recall, we have a base plan that's 100% paid by HCS. We also allow our valued employees to buy up to increase their maximums. We also offer vision benefits, flexible and dependent care, employee assistance, and then for the last couple of years, we also have our 3 on-site clinics. Just remember, we have one here in Hickory Valley, in Hickson, as well as Riverfront, and then we have 2 on-site pharmacies, Hickory Valley as well as Hickson. We also offer for our employees virtual mental health, text care. Text care is really what it says, right? Our employees can text the clinic, they get rapid response to figure out whether or not they need to come to the clinic or fill a prescription, whatever it might be. The board also offers basic life, accidental death and voluntary insurance, short and long-term disability, accident insurance, critical insurance, or critical illness insurance, as well as our hospital indemnity package. So that's just the overview. You can see that's a rich plan. That's a lot of benefits for our valued employees, and we like these. And I believe that all of our employees appreciate what we offer here in Hamilton County. I'm going to pass it over to Mary Ellen just for a bit and let her explain some financials to you when it comes to the current state of our self-insured plan.
Right, so we are self-insured. So that means, I think folks think like we have Blue Cross, that the Blue Cross they do handle our claims, but we actually are self-insured. So that means that we actually, when there's a claim comes in, we pay it versus Blue Cross kind of spreading our risk among everybody. It's really among all of our employees. So we pay Cigna, we pay Blue Cross. There's some plans that are voluntary, so those are really between the employee and the vendor, but we basically are a pass-through on those, but our health insurance is all self-insured. And then we have a stop loss, so if we have a big claim.
Excuse me.
Yeah,
Yeah, you need to,
okay.
you've got to speak into the mic or those
He's got a
that are
teacher voice.
online cannot hear you.
Yeah. Teacher voice, I don't got that.
We're hiring teachers.
That's not me. Okay, is that better? Okay, so the stop loss agreement, so that makes it, so if we have a $500,000 claim, we've got an extra insurance plan that we're liable up to $375,000, and that would cover us and protect us against really large claims. But again, if you have a series of those for each claim, it's $375,000, so those can add up, but at least kind of protects us against those really catastrophic claims. And I think we're going to turn over to Brent to kind of talk about kind of just the general state of healthcare and what they're seeing as market trends.
Sure. I'm Brent Wick with Russ Blakely and Associates here in town doing the benefit consulting. And Katie, I'll let you introduce yourself.
I'm Katie Petty, and I work for Russ Blakely and Associates as the Director of Underwriting.
Joe, want to let them, yeah, you can go ahead and introduce.
I'm Dave Kinsler, CEO of One-to-One Health, so we operate the clinics.
I'm Josh Sanders. I'm the Director of Pharmacy for Onsite RX, and I was the previous pharmacy manager at the Hickory Valley location that started the pharmacy.
So a couple
Just
of,
remember to speak into the mic for everybody.
sure. So just a couple of things to think about as we talk about healthcare costs and benefit costs going forward, just what the economics look like nationally, but then also locally. So nationally, you compare trend. I think there's a couple articles also that have been provided, but national healthcare trend is expected to actually increase in 24. We've been in the 6% range for the last 5 years, a little bit beyond, and next year is going to go up to 7%. So we do have some headwinds as far as what's going to happen from a cost perspective. A lot of that, you think about what happened from COVID perspective, hospitals, everybody had to pay significant increases in labor. No surprise. I mean, everybody's been faced with that, but it also now is starting to play out in healthcare, and then technology is a huge part of that. The innovation of pharmaceuticals and those types of things really continue to drive a lot of the cost increases we see across the plan. If you look back to important to kind of pay attention to is what's happened the last 5 years. So the school board or the school's plan has actually increased by to over $23 million. over the past 5 years, so a pretty significant increase during that time. There haven't been plan changes or premium increases, so pretty significant cost increases. So it's a matter of how do we start to mitigate that to allow the plan to be sustainable going forward. Some of the cost drivers, yeah, we'll go through. So you think about things that have happened. COVID obviously jumps out of the page, right? As far as we had significant impacts, those were unforeseen costs. Everybody got hit with that were several $1 million, but that's not the only thing that has impacted just the overall rising healthcare costs. So medical inflation. You think about cost of healthcare. There's two things that really drive it. It's what was the quantity you purchased, and how much did you pay for each thing you purchased. And so you have inflation on the side of what we're paying for them, but we also, quantity can be impacted as we see potential decline in health or additional risk factors within the population. So the health of the population becomes extremely important in how people take care of themselves, and that's more focused on how are they doing their preventative things and taking care of getting the care they need when they need it, because that's what actually will lead to better cost outcomes from a long-term perspective. The increase in headcount also is kind of the obvious. We're paying for more people, so that obviously drives costs when we talk about on a total budget standpoint. And when we also look at just the increased burden of disease and specifically chronic conditions, which is not abnormal, we see this across the board. Do a lot of consulting work for large entities within our region, and chronic condition discussions is the #1 cost driver we're talking about consistently, and a lot of that's geographics where we live, and that is having a significant impact on cost as well for the schools. So how can we start to address those going forward become really important.
Thank you, Brent. I want to draw your attention back to this slide here. When we think about, earlier I mentioned all the benefits we offer to our employees, but I really want to drive home the message here to the board is that we have not increased our premiums in the last 10 years, right? And so ultimately I listed out all the benefits we offer our valued employees, but we've added a significant amount. And so this slide shows everything we've added, again, at no cost to our employees. Those 3 wellness clinics, the free services to all of our employees, the text care, the 2 pharmacies in Hickson and Hickory Valley. If you go to a pharmacy for our employees, those free generic prescriptions, again, at no cost to our employees. The mail order, right? We recognize that we started that last year where for all of our employees, that's, it's hard to get to the pharmacy, right? So we've instituted the mail order from our Hickson location. Free wellness, nutritional coaching, behavioral mental telehealth has been huge for our staff. Increased district paid life insurance. I believe we doubled that from $20,000 to $40,000 for our employees, and added short-term disability to replace the sick leave bank. And then we added the dental insurance plan, which I mentioned earlier. That base plan is at no cost to our employees. So again, this has been a significant improvement to our benefits, no additional cost of premiums. We feel this is a good thing, right? This is a good thing when you think about our strategic plan, every employee valued, but we have to recognize that it's been 10 years since we've increased premiums. The next slide, I'm going to let Brent jump back in. He's mentioned the increased costs of medical, but also there's been an increased cost in dental as well. Can you speak on that, Brent?
Yes, so since 2019, we've continued to see some cost increase that included dental with a pretty significant increase. You can see 30%. And one of the things even done trying to get ahead of that is change how the dental plan was administered and moved to an insurance plan instead of the reimbursement plan back in 2022 to try to mitigate some of that, but that's still been a significant cost increase as well, based on that's purely a drive of utilization more than anything.
So we wanted to give you kind of just an overall just cost perspective. What's the kind of the bottom line? And so this slide kind of tries to do that. So really the benefit costs, and that's everything. That's not talking employee contribution, but just what we pay for our healthcare, dental, life insurance. Unemployment's a small piece, but it is in there. That is that cost. It also includes the clinic and the pharmacy. So that is the total cost. And you can see the increase from fiscal year 19 to fiscal year 23 is to the 23.7 million we mentioned earlier. So just the math there is 42% increase. Again, it's a combination of things. It's the cost, but it's also we've increased the actual benefit offerings. So it's just a lot of different factors in there. And then we want to just comparison something Mr. Perez had mentioned, which is how's that compare to our GP budget. So in 19, you can see that was 14% just in comparison to our GP budget. It's grown to 17% of the budget. So it's basically the costs are growing faster than our GP budget is. So that's obviously a sustainability issue, looking at that. And since we haven't increased our employee costs other than headcounts where more employees are paying, it's a cost that we're having to bear. We've funded a lot of that increase through accumulated reserves in our self-insurance fund. So the way self-insurance works, you figure out how much we can contribute from the budget, and so it's kind of a savings account. And in general, this is how people manage the plans. It's kind of, so there's some years it goes up, some years goes down. You kind of build up, and then just so you can kind of keep a straight line to your budget as you need to, and you can kind of dip in, and then other years you kind of use it up. So we've been kind of on the using it up process for the past few years. I think with COVID and with just kind of where we were with our employee base, that was the right thing to do. But now we've got to figure out what's the sustainability of that, because there's only so much money in that fund. So we'll have to continue to watch that and really start trying to figure out how do we keep it, kind of start replenishing it and trying to find that balance. And sometimes, you've got to wait to get the information, see where the trends are. I think part of the clinic and pharmacy, hoping that would help us mitigate costs. And we know it has, and certainly the pharmacy costs. Means for example, we're generating, and not to take Josh's thunder, but we're getting rebates just of like $8 million on our on-site pharmacy. So that's helping cover a lot of the costs. I think it's things like that. We have to keep thinking of creative ways to do that. And I think that's one of the things we want to cover today. And then just to give a little bit more detail is the next slide on the detail of where our medical costs are coming from. So you can see that the majority of our employees are going for the Cigna plan, which I think our Cigna plan is definitely a very rich plan, and a lot of folks have chosen that because it's a very good benefit for the employee. You can see in 20 is when we introduced the pharmacy, and so you can see it's got some small costs once it was up fully running in 21. But that is net of, that's covering the cost of the drugs, the cost of the staffing, and then net against those rebates. And then you can see kind of the increase from Blue Cross and Cigna, so you can kind of see where the bulk of that cost increase has come from. And then we also wanted to show you a trend. So if we just basically take the 7% healthcare cost to both plans, where that would grow over the next 5 years. So just kind of say if we don't do anything, this is where we would end up as far as the total net cost to the district. I'll turn it back over to Brent to again talk about some kind of benchmarks about how our plans are structured.
Yeah, so just to try to give you a picture of how things stack up, and these are national benchmarks that are done, and there is some, you'll see some state information there as well, and then you can also see by employer size. Everything stays fairly consistent. There's some variable as you look at that, but if you really look at the school boards and other institutions, you see that from a benefit standpoint, at the very top there, you've got the benchmark showing a $700 deductible, whereas the Cigna plan has no deductible. The Blue Cross plan has a $450 deductible, so it's a pretty significant difference. The same with what percentage the employee actually pays after deductible. So under Blue Cross, the current plan, it's 10%, whereas under the benchmark scenario, they're paying 20%. And in the HMO, there is no, everything's paid 100%. You just have the co-pays. The out-of-pocket's also pretty significant at $3,000 for the benchmark versus $1,750 in the current plan with Blue Cross, and only $1,000 with Cigna. So there are pretty big differences in the actual benefits themselves. Also, if we look at this from just local perspective as well, you would see very similar in gaps between the two. So you'll maintain extremely rich benefits for the last several years. It does have a financial impact. The employee costs also are listed there. You can see the employee and family tiers just as a benchmark. And so currently employees are paying $100 a month for single coverage and $534 for family coverage, which are both below what you would see in the benchmark perspective. So just to give you kind of some comparison of how things stack up. The pharmacy benefits also are important. I mean, pharmacies are the one benefit that just about everybody that's covered under the plan is going to use throughout the year in some form or fashion. So this has the most impact to employees that are covered and their families. And you can see that if we use the same industry school boards and other institutions in every tier, whether it's a generic or preferred brand or formulary brand and non-formulary brand, the copays are below what the benchmark would be. The other thing that's not noted there, so this is the additional benefit that's been provided, is the on-site RX copays. So for everybody that goes to the pharmacy, they actually are paying $0 for generics, $10, and then $20 for the non-formulary and specialty. So even a much richer plan. But that is what actually creates additional opportunity. So it's a matter of how do we continue to use the pharmacy more. The more volume that's going through there, it actually creates a better path to sustain the cost equation and continue to offer those same benefits.
Thank you, Brent. So Chairman Perez, we're going to jump into recommendations, but I want to pause just for a moment if there's any questions that we can field before we jump in to our recommendations moving forward.
Ms. Robinson?
Yes, I would like to know if the claims department audit, what are the red flags that you look at to audit a bill?
So so just to be clear, I guess, from a process, right? So within Cigna and Blue Cross, so they pay the claims. They're the ones that claims come in from the physicians, hospitals. They're the ones reviewing it, matching up against the school benefit package to determine how that claim should be paid, applying the discount to that, and then paying. So there are built in, both Cigna and Blue Cross have audit functions that are included in that. Certain it varies within each carrier slightly, but each bill that's above a certain threshold is always going to be audited before it's actually processed. And then a lot of your lower cost, maybe you're looking at your physician bills, those types of things, actually in today's world, the vast majority of those are actually auto adjudicated, because as long as all the data is there when it comes in, it's going to auto process through the claim system. But your large bills are still audited.
Does Hamilton County physicians have a chart to go by for certain things as versus the other region of the country?
Chart in what?
Well, pay a cost for a doctor visit.
Yes. So.
Or X-rays.
Yeah. So part of the reason of using Blue Cross and a Cigna, right, is so because they have negotiated fee schedules that are in place, and so we tap into their fee schedules that they've negotiated. So in terms of the actual function, Blue Cross and Cigna handle all aspects of the administration, but instead of the money coming from their account, right, they actually take that money from Hamilton County's account to actually pay their provider, but all the other functions happen by them.
Okay, thank you.
You're welcome.
Anybody else? Yeah.
Probably a crazy question. How much have we, over the last year, spent out in claims versus what we've taken in premiums? What is it, is that number available?
Yeah, so,
Maybe
yeah,
I
yeah, I
just
think
missed.
there's a handout. So for '23, our employee, so contributions from current employees was 13.2 million, and from retirees was just over $1 million.
That's what we paid out.
That's what employees have contributed.
Okay, so what did we pay out in claims?
That was that, so that was the total for all the benefits for '23 was $80 million.
We paid out 80 million, and we took in 13 million.
From employees, yes.
Okay,
And so the difference comes from our general operating fund.
okay.
So we contribute to the self-funded, and then the self-funded is where we actually pay the claims
Okay.
out. And so over time, each year in the budget, we decide how much we're gonna put into self-funded.
So that.
We've been paying the last few years, we've been using
Mhm.
our contributions from the employees, contributions from GP, and then savings that we had built up over the years. We were aggressively putting money into the self-funded more than we were paying
Well, I can see
out.
why that's concerning.
Yes, yes.
So one question I have, because we've mentioned COVID, but we also received a lot of unexpected funds for COVID. Did we use any of that to help? So we didn't use anything to help cover some of those costs?
Not directly, no. So we'd used it to help cover absences for our substitutes. We used it for those types of things, but we didn't use it to directly. Now, there was some things that we may have paid for some COVID clinics and some of those things, which would have offset some cost.
All right, any other questions? It's a lot of information. I think it'll take us time to process in many ways, but if you've got questions for now, if not, we'll continue with some thoughts.
Okay. Okay, so directly getting at, what do we do next, is really looking at cost control and plan sustainability. So what we're looking at for our target as the first attack at this is trying to capture $10 million to kind of make up that difference over what we've been putting in. We did put in our '24 budget, we are putting more into self-funded out of GP. So we're contributing more directly from our budget, but it's not enough to completely close the gap.
How much are we contributing? Can you remind me?
My guesstimate for '24 is about 55 million from all sorts of funds, versus we put in about 45 in '23, so about 10 million more. So again, the gap of about 20 is kind of our target. So it's how can we control costs, and then to make the plan sustainable. So we don't want to just get a one-year fix. We want to think about this long-term so we can continue to provide great benefits for our employees, but make sure it's manageable. So there's kind of two components. One of them is plan cost management, is what we're going to dig. But the big savings that we're going to see is really going to be from behavioral cost savings. So some of the things Brent alluded to. So utilizing our pharmacy, we are able to get a better pricing on our pharmacy. So if we increase that, I think that will drive down our costs. Wellness engagement, because if people are healthier, so if they do some things we suggest, engaging with that can help drive our costs down. So I think COVID probably driven that because people are staying in their homes, not exercising as much, so we've probably gotten some health challenges there. And then chronic condition management. So people that do have chronic conditions, if they're more engaged on that can help drive costs down. But sometimes we need to find some things to help encourage that, because sometimes people don't always do that on themselves. They have to have a driver to do that. We can't necessarily directly get at that. So what we can do is some things on the plan management to help drive some behavioral cost improvement. And I don't know if Brent's got anything to add on that perspective.
No, I think the resources we already have, I mean, that's kind of the advantage. You have invested significantly in great resources that can help drive a lot of the behavior and the cost. It's just how do we deploy that as aggressively as we can, because that's the way we can kind of sustain the cost the best way.
So we're going to look at a few components of the things that we can actively change. A big
Go
thing
ahead,
is.
Mr.
Oh, sorry.
Let me,
Yeah.
I hate to interrupt you,
No.
but I saw it earlier, and then I see it here again now. Why do you think that we have underutilization of the pharmacy and is it location? Is it, why
Not
is?
anymore.
I think part of it was timing of when we rolled it out. I think that was one.
Yeah, I think some of the recommendations, sir, is gonna, we've yet to adjust in a sense of, the benefit of going to our pharmacy over at Walgreens or CVS, and some of that is what the plan cost management, Mary Ellen, is gonna get to, is like, we've gotta create a pathway so folks feel like, hey, look, there's a great benefit of going to our
Yeah.
pharmacy over someone else's. So we've got to encourage that behavior, and part of our recommendations will, in our mind, encourage folks to take advantage of our pharmacies as well as our clinics and I was thinking mail order as well. So.
So we'll dig into this a little bit, but so I guess one is plan design changes. So that's just thinking some of the things we looked at compared to others. What is our deductible? What are some copays, some different things with that? Pharmacy copay is a specific thing that we really think we need to look at, again, comparison to market, and that would drive, obviously, if we know we can save more money using our local pharmacy, we can encourage go into our pharmacy, that will help.
Sorry. You said we are doing mail order. Are those deliveries being going straight to the employee's home? Okay.
You want to speak on that, Josh?
Yeah, so we just implemented that last year. It's out of our Hickson location just due to licensing, but yeah, we ship straight to the patient's home for anybody who lives in Tennessee and Georgia, and that's at no extra cost to the patient. So we're trying to remove any barrier to utilizing the pharmacy.
Would there be a cost benefit to us to deliver to their workplace?
Not necessarily, and there's a lot of legal issues that go in with that.
Yeah.
Chain of command of the drugs, a lot of times it's been brought up. We can't just take it and drop it off at a location. There has to be a pharmacy member, staff member there, lots of HIPAA things.
Concerns and
Yeah.
I mean, usually packaging takes care of HIPAA stuff, but yeah.
Yeah, but
Okay.
as far as the pickup, you can't have, like, even HIPAA extends even to knowing that it's a pharmacy package with someone's name on it, so we're not allowed to leave it in a mailbox at a school system. We would have to physically have a member of the pharmacy staff there to hand it to the patient, and then you also have to fulfill counseling needs, so we have to be able to speak to the patient, and that's taken care of with the direct mail order to their house. There's a slip of paper and a toll-free number that they can get in touch with a pharmacist and have any questions answered. So yeah, that cost right now is roughly around $9 or so for a package to mail directly to the patient's house, and that satisfies all the HIPAA requirements.
Okay, and so employee contributions, again, that's another place that we can look at, and dental cost sharing. So we're gonna jump into the details on these. All right, Brent, talk about the proposals. So at a recent board meeting, we did an RFP for our benefits, and we brought those to you, but now we want to dig into those a little bit more.
Yeah, so just kind of looking at high-level perspective, the goal would be to maintain the 3 current plans, the one with Blue Cross and 2 with Cigna, so those would stay in place. And then in addition to that would be the pharmacy copay, so keeping the pharmacy cost the same within the Ed Health pharmacy, so not changing that, which that becomes one of the keys to continue to drive that utilization that was just mentioned. A couple of things that, as we look at things that can be done to the plans to drive some cost savings, there's also some things that we feel like should be adjusted just to make things a little more sustainable. One is the current plan that's offered, the Cigna plan, the HMO plan, is extremely rich, and when you compare that to the Blue Cross plan, there's actually a pricing differential, but it's actually the same price to the employee. So everybody that picks the Cigna plan drives a little bit greater cost. So one of the goals is to bring that to where they are comparable. So not necessarily changing what the employee pays alone in that to fix it, but just adjusting the benefit some. So we'll walk through that, but that's one of the goals that we want to make sure is just so that as employees choose, it doesn't have a financial impact depending on the direction they go.
Because we also think we're going to have a number of employees who will move from Blue Cross to Cigna because it is expanding to 50 states this coming year. So folks who have children in other states, have probably been on Blue Cross, but now they'll probably move to Cigna.
So because I want to clarify that for those, many of us probably know, but the Blue Cross Blue Shield plan has already applied to everybody, no matter where they're located. So like in my case, that I have children outside of the state, that plan would work. It's not the most robust plan, it's not the best plan for a family. The Cigna plan, the concern with children out of state is that only in emergency, really, not for regular care, does the Cigna plan kick in. So by this change, all of a sudden the Cigna plan becomes available to everybody. And it is a very good plan. I don't want to say anything that Blue Cross isn't. It's also a very good plan. But so those that will choose that, being that it's a more expensive plan for our system, it's going to increase the cost for that as well. So.
So hopefully you can see this well in front of you, but wanted to give kind of some snapshots of what things look like to try to achieve a savings goal that's been laid out of the $10 million. What does that look like? So what you're looking at here is just an option where this is done through benefit changes. So leaving payroll adjustments aside, this is what it would take to adjust benefits to achieve that savings. And you can see these are not immaterial changes, right? We are significantly, it would take significant increases to the deductible for both on the Blue Cross plan, but it also would take increasing and adding deductibles to the Cigna plan as well. So in essence, what you end up with is the Cigna plan, instead of being an HMO style plan that's co-pays, now everything's deductibles and co-insurance after deductible, still maintaining some co-pays on the Cigna plan for office visits and all, but still a pretty significant change just in how that plan works compared to what employees would be used to. This also does include changing the pharmacy co-pays. If you look there at the bottom, so the left side is going to be your $20 copay, so that's going to be at retail. So if you're not going to the employee pharmacy, that would be the cost, whereas if you go to the pharmacy, you would still maintain your zero cost. That move is twofold. One, it does help save, but it also creates an incentive. Other clients that we work with that have pharmacies, just like the schools, all of them have pretty significant cost drivers. The utilization of the pharmacy, the cost there for the employees is typically very inexpensive, but if you choose not to use it, then it becomes a little more expensive. So that change is recommended to be made on both plans. So that gives you kind of a perspective, just from a high level. If we make all the changes from a benefit, what would that look like? Obviously, there's lots of ways to get there, but hopefully just to paint a picture of what it would take to actually get to drive the $10 million savings.
Brent, let me jump in real quick. I just, we share this, just, I know it's a concern about raising premiums and all, and this is keeping premiums at bay, dealing with our pharmacy, which we need to, but ultimately, I don't like this plan, right? I think it really changes what it's gonna, when I think about every employee valued, this is gonna be a hard pill to swallow. But it is a savings, a big savings. So I just wanted you to know that I wanted to share an option where, if the board says, let's not change premiums, well, this is what it's going to take short term to try to get to our $10 million savings, okay? So Brent's going to share something that we feel is a better solution, and it's going to be cost savings, but also is going to be put us on the road for sustainability.
If I can go back to that, I mean, I agree with you, perhaps with the exception of the prescription drugs portion of it, because we're providing a benefit that is almost, I don't want to say it's always free for everybody, but many times it will be free for people for the same medicines, for the same situation. I do think with the deductible change, though there's ways to mitigate that, but yeah.
Yes, sir, and to be real clear, the pharmacy is going to be the same on both
Yeah.
our options, because we feel that is the best way when we think about cost savings and we think about behavior changes. And then, of course, we've done lots of things to provide for all of our employees when you think about mail order, the 2 sites, et cetera.
Yeah, so if we look at, to Dr. Brown's point, maybe a better approach is balancing that sum with how do we solve between the Blue Cross and Cigna options to try to keep those so they're balanced, they're equal, what we refer to the actuarial value of those being the same. And then looking at also keeping the high deductible health plan, leaving that intact, not driving the cost up, so there is a low-cost option that's still available for those that would like to keep their paycheck as low as or as high as possible by not putting that in benefits. But we also then would look at potentially an increase in employee cost share. And so that's what the next option is, represents a little more balanced approach to that. So if we look at, this is the rebalancing, you'll see the things in yellow under Cigna. The out-of-pocket goes up slightly from $1,000 to $1,300 for individual coverage and $2,600 for family coverage. We still maintain 100% coverage, so still all you pay is your copay. The additional things that would change under that plan is for urgent care services, those would increase $25, so going from $50 to $75. The hospital inpatient services from $100 to $125, and then also outpatient services from $50 to $75. And the last item there is MRIs, PET scans, so all your high-tech imaging services would actually have a copay of $100 instead of no cost today. The pharmacy, just as we talked about, that is exactly as it was on the prior page. But this benefit approach then solves kind of what it looked, the balancing of those, but also with the pharmacy change, obviously is driving some savings by hopefully getting people encouraged to utilize the pharmacy that's been provided. The savings from this plan based on rebalancing the pharmacy changes, some slight contribution changes that would be in that, so in essence $115 instead of $116 with an additional option is going to be $4.3 million. So doesn't get us all the way there, but a starting point, and then how contributions, and I think we've got multiple ways to look at contributions, and some of those have been provided as well, just to give a better picture of what could be done to get to the place needed.
Okay, so you have a handout with a possible structure for the premium distribution. One of the things that we recommend is basically, yes, that is you always think about the premiums kind of in a dollar amount, and we need to think about a share, like here's our cost of health care for an employee, how do we share in that? So looking at a percentage of the premium cost. So each year we kind of look at what the costs are, and then that sets the premium, and there's actuarial, lots of complicated math, but they figure out per individual family, here's what we should charge a premium to cover the cost. But if we share in that, then we can really look at what we're doing in the future, and if we actually have savings in the future, everybody will benefit, because both the employee and the district. What's happened these past 10 years is the district has gotten upside and downside of it. So if there's been years where we've saved money, we've benefited. If there's been years we've cost more, it's cost us. If we do it together, work to become healthier, we both benefit, so we can mitigate costs that way. So doing that kind of basically, we've both got skin in the game, looking at the changes in costs from year to year and how do we best mitigate that. So those are looking at the options kind of recommendation, and I think there's also a plan. So the current plan that we have would be the top section, that's the PPO and HMO after the rebalancing. But then there's a narrower network that Brett might be able to speak to, which is a not all the way the high deductible, but another plan option that tightens the network a little bit, but produces some savings, so you don't have to go up to the next tier.
Yeah, so just one of the ways to create choice, some savings as well, is both Cigna and Blue Cross offer a narrower network, and both of those options wouldn't include Park Ridge Hospital. The intent of doing that would be offering both Blue Cross and Cigna their large networks and their small. So it would be a choice to employees, contributions being slightly less for the smaller network, but the benefits themselves, so the benefit under Blue Cross would be the same regardless of which network you chose, and the benefit under Cigna would be the same regardless of which benefit you chose. So in a way to increase some choice for the employees to be able to decide access points, and also that would affect their contribution as well.
And this is after considering the plan change. So this is with that, this is an extra layer on that. Yeah, with option one, not the higher plan. And then you'll see also on the high, as we mentioned, the high deductible plan, there's no change in premium. So that's a way to, again, help families decide the best way to manage their paycheck.
One additional option, and just maybe one comment that's worth, is the idea of a percentage and sharing in that is something we see commonly as a move, because it does create if we can drive healthcare costs down, there's a win for everybody, but it also keeps from having that significant trend, because it compounds. If everything stays the same, that means costs are compounding, and so it helps avoid that scenario where you get to a place where major things have to be done. One of the from the other extreme scenario that could be done is the schools actually has the option, you could go up under the state plan and offer the state of Tennessee benefits to the employees. From a process of that, you actually have to send the information into the state. They will give you cost comparison, or the cost of doing that, and what it would be, and that's in essence.
Is this in addition to what we're offering, or is this
It would be a replacement.
separate?
Yeah.
Replacement, okay.
Yeah, you would have, the state doesn't allow you to choose. You have to go, you're either in the state or not.
All right, I'm going to take questions. Ms. Robinson, is your
Well, I
turn?
was going to address that, because it says we have the option to join, so that would be totally separate, and we don't know what company that it would be.
So they actually offer, the plan is unique and self-funded, but you would pay just fixed amounts, like as if it was insured for you all. So the state, you submit your data to them, they create rates and tell you this is what it's gonna cost. The administrators for that plan are both Blue Cross and Cigna.
Okay.
So it would be similar, I mean, you would have similar to what you have. The pharmacy is done by a different PBM than Blue Cross and Cigna, though.
So it might be seamless to not.
Yeah, the benefits themselves, I think that's,
They should have.
yeah, I think you have a copy, and you'll see there's a pretty big difference in
Oh,
benefits. Because they dictate the benefit. It's
And how about-
based on what they have.
And then, in-network, how will the insureds know, how the information on that?
Under the state plan?
No, under the, through Blue Cross Blue Shield and Cigna.
So,
Locally.
yeah, locally, it's just like your current, so under the Blue Cross arrangement, Cigna arrangement now, so it's their standard network is what we're tapping into, and then the state also taps into the same. The state does have slight variation to it, but it's not very different.
All right,
And
thank you.
you can also go to their website and look up your specific plan and see if your doctor is covered.
Okay, thank you.
Ms. Black?
Dr. Brown, what is the median pay of our employees like?
Yeah, that's a good question. I have to get back with you on it. I guess you're saying classified, certified?
All of our employees, median pay, because I'm wondering, we just gave a 5% raise. For the median employee, how much was that raise in their monthly paycheck versus what we are proposing to increase their pay, like, their premiums by is, I mean, are we eating their entire raise?
Yeah, I can answer that question. I would say no. You know, if you look at the narrow networking, thinking, I'm just looking at the employee, right? If we went with option one, and correct me if I'm wrong, Mary Ellen, it's $20 a paycheck, right? And so you think about that times at 26, that's relatively a small amount. That doesn't even come close to our 5% that we gave our valued employees. Again, you know, if you think about, we made an intentional effort to make sure that to give our employees option where we didn't increase the premiums for the high deductible because everybody's situation is different, right? And so that is an option where it's still going to, what they're paying today, they can continue to pay. But also, even with the plan, with the $29, I'm looking at the single employee, that's really relatively a small amount when you think about over the life of the year. And, you know, I want to go back to we're thinking about sustainability. You know, I think when we were trying to figure out how we attack this to make sure that we make sure our employees know that every employee is valued, but I don't want to be back here next year, right? And I think that's why I really want to emphasize when we think about a 20% cost, in some ways, you know, we know that 7% increase on medical insurance year to year, whatever it might be, we're all in it together, right? And so we continue to change our behaviors. We save money. We all save money. But what we don't want is to not address it this year, and then next year we're sitting here again thinking about another X%. And I think that will go a long way to really discourage you know, whatever the board sees to give our employees a raise. And I will say the cost savings, you know, we haven't really talked about, I know we got a few more slides. I would think about the cost savings. It's one of these things like what else can we do with these funds that we save, right? And so if we're trying to think about the $10 million of savings, well, it takes about, for a 1% raise, about equivalent to $4 million, right? And so you think through all the cost savings down the road, how else can we give back to our employees? That's an option there. Of what do we do with those funds going forward? So.
And we also want to make sure we educate our employees on the high deductible plan. It sounds scary, but it's really a good plan, and
For a lot of employees, it can be.
Yeah, and we have
That's
very
true.
few.
There's an inverse
Yes.
correlation between low pay and health risk factors, right? I mean, that is just statistically true. The poorer you are, the more likely you are to have health risk factors and be put in a place where you couldn't afford a high deductible plan. You would need better insurance to manage your health conditions. And so that's kind of where my mind is. I know we have to look at sustainability. I'm just trying to get a grapple on the numbers of like, what is this actually going to do to the paychecks of our employees? If we have a lower paid employee who can't choose that high deductible plan because of their chronic medical conditions, what does that do to the raise that we just gave them?
Right, and Dave's going to talk some more about how our clinics can help with that and help manage those diseases and employees who have a lot of needs, and they can do that for free. So that's something that we can talk about.
1 second, because
too.
Mr. Groen, you had yours on, but did you turn it off? Did you?
No, thank you, sir.
Okay.
If we're looking at overall plans, why wouldn't we have already reached out to the state?
I mean, I think
I
we
mean,
could
if
do that. We would have to
if we're truly looking at options, why wouldn't we have already reached out and done the research on this?
It would take a significant amount of data and information to undertake that, and we feel like our current plan is a much better plan for our employees. If that's one of the reasons for tonight is information. If that's the direction that we really think that's a viable option, we would put the effort into doing that. But we're recommending staying with our plan and making the modifications. So we just want to make sure we put our effort into the right work.
And if we are spending 80 million and we took in 13, considering the increases we're going to have, how is that sustainable?
That's what we're addressing is,
But it doesn't look like we're addressing that.
We've put more in from our budget. That was part of our budget is funding more from our budget into it. we're proposing getting the costs down, and then how we share in the cost of those things, and then, and looking at going forward, again, continuing to improve behaviors that will drive costs down. That's the sustainability. I mean, that's really the big thing that we need to do, is get our healthcare costs down. If we don't do any of these things, it has to come out of our budget. So we have to either go to fund balance, we have to make other decisions when we make our budget next year. We won't be able to fill as many teacher positions. We won't be able to do, I mean, that's, we can't do as much in raises. I mean, that's what we're, trying to address and look at it sustainably of what we need to do.
Well, I'm trying to wrap my mind around this. And so here's what I heard. So please correct me. So $80 million, we're looking at a 7% rough increase in cost. And instead of taking in 13 million, we're going to take in 23 million. So we continue to have a huge deficit that we're having to pull out of a general fund or increase our request to the county commission. I still don't, maybe I'm just ignorant, but I just don't understand how this is sustainable.
Yes, sir. I do want to add, and Brent can help me here. I will say that if we think about just an employee, right? If they're currently taking about 12% of the premium of our costs, and then we move that to 20%, and then we think about what's the cost saving just by changing our plan, what's in the plan, then changing premiums. Is that close to 10 million? But I'll also say that our hope with all the other changes we have in place, behavior change, if we have a 40% utilization now at our clinics, if we get that to 80% utilization, that's going to be more of a saving. So I think there's other things that it's going to happen with the plan change that's going to create the opportunity for more savings. Am I?
No, absolutely. And it just, from a big picture too, just to make sure that, so use the rough numbers of $80 million. The 13 is just the employee portion, right? A lot of those, the schools have funded a huge portion of that for a long period of time. And so there's always been a portion that comes out of the general budget to go towards healthcare. The issue is just that continues to grow. So that's not the only dollars that have been funding healthcare. It's the combination. The 13 is just the employee portion, which is the smaller percentage. But to the point of just the sustainability, it does tie into how do you drive a better result. You talk about for those that maybe need a richer benefit and all, which is an absolute reality, right? And that's the stuff that you've already done with the clinic, because anyone can go to the clinic, right, for free. There's no cost to go there. And then in addition, you get your generics from the pharmacy at no cost as well. So, I mean, continuing to maintain those avenues are really important, but by keeping those avenues, we also continue to drive cost savings. Because not only are they now have access so they get care instead of avoiding it if they couldn't afford it, but now you're also actively managing the condition. You're taking medication when you were prescribed medication instead of avoiding because you couldn't afford it, those types of things. So those resources play a big role.
Thank you. Dr. Brown, something you said was the first time I heard this, is that our employee contribution is going from 12% to 20%. Is that correct? Did I hear that correctly?
The premium. I think it's on this sheet right here is the option that we gave you.
Well, you have to understand, we were thrown all this information just before this meeting started.
Yes, sir. Again, this was just this is why we felt like we wanted this conversation, right? We're trying to, we've been digging in as well, and so we wanted to get in front of you, and I apologize for not being able to get this to you sooner.
So I want to be clear about that. We're not voting on anything.
I understand.
Yeah, this is just for information. It's so that we receive this information publicly, so that the public is aware of the information, and
Two choices.
and if we need to have 2 or 3 more meetings, we
Yes,
have
sir.
them. But yeah, so this isn't a meeting for a vote.
Yeah,
I understand.
There's a range, sir. Just so to be clear, there's three plans: the PPO, HMO, where we're currently at. If we thought about the narrow network and then the high deductible, so it's a range from if we went with this option, employee could be 20%, or it could be 18%, or the high deductible will maintain the 7.8 approximately percent for the premium as well. And the idea here was really, we think about every employee value, is how do we have a sustainable plan, but also how we give people choice and options, because every family is different. But that is definitely an increase if you think about the current PPO HMO for an employee, single employee, approximately 12% to 20%.
But yet we've already been told that, one more thing, yet we've already been told that Cigna is changing, which is going to supposedly drive a majority of the Blue Cross Blue Shield into Cigna.
Yes, sir, and that's the reason on this slide here that we really wanted to kind of help address that. While we did change a few nuances within the plan, right, where we think about the out-of-pocket, and we also thought about the urgent care, inpatient, those other benefits as well.
Ms. Thurman has.
Yeah, you've said something a minute ago, a lot of people don't realize, but I've been around a long time. I remember at one time, zero cost for employees to have health insurance. Were you y'all around then?
I remember the $99 single rate.
It was zero, and then it went up to 50, and there was an outcry, and then it went up to 100, and there was another outcry. And but the cost of health insurance has gone up, and I've always said, this is one reason I always wanted to figure in the cost of benefits in teacher salary when we consider what our teachers make, because this is a very rich plan. A lot of people don't realize that, because when you see what other companies offer and what they cover, and this is a very, very rich plan. So I understand where the cost is going with this. I mean, I understand that. But you are correct that a lot of this has always been figured into our base budget, that we've covered some of this for the employees. And a lot of times we don't get credit for that, but we always have. And I've always thought that that should be figured in on part of the salary, because even all of the school systems around us don't offer plans this rich. So then when we're comparing salaries,
Yes,
we
ma'am.
need to look at that, and we don't always do that. But I know the cost of healthcare has just skyrocketed, and I appreciate all your work on this. It'll take a while to absorb all of this, but I just want people to know at one time it was zero, but we still covered employees, but it's just gone up and up and up, and but people need to know that we do have a very rich plan as compared to the people around us, the other school systems.
Yes, ma'am, and I echo that.
Go ahead.
I echo that, Ms. Thurman, just so the board knows, like, we recruit that way, right? You know, the first 5 years when you're young, out of college, whatnot.
Yeah, you don't
insurance-
think, well,
we're not
whatever, I
thinking-
don't need
But we recruit some veteran teachers when they think about the 10 years, the 15 years, and a lot of that is, you know, salary is one thing, but they look at benefits, right? It matters. So that's one reason to the board is like, we want to continue to offer a great plan, right? So we want to figure this out. But you're totally right. When it comes to recruitment, you know, benefits is part of the package.
So, before I go to Ms. Robinson, I do want to apologize to the board. I set this meeting from 6 to 7. It is clear with the information that we have that there's no way it's going to be a 6 to 7 meeting. And again, it's only a work session, so we're not voting on anything. We're informing. That's why the board members who couldn't be available will get this information as well and process it. And if we have to have 2 or 3 meetings, I know that you would like to have a vote by September, which I know is soon, but because of the fact that open enrollment begins, so we want to get open enrollment so that people know what they're getting. So it is this, you know, and all of us who've worked in business who have had to do this know that this is how it works every single time. You're rushing through plans, trying to get what you need for your, you know, we're blessed that we get options. In a lot of places, you're told this is the one option, and and usually it's high deductible,
Yes.
and there's not much more that you could do about it. And it's always been my job to let the employees know that's what we have this year. So it's not an easy conversation. Ms. Robinson.
Well, I was going to get the math closer together. How much have we put into the self-insured account in the last 12 months?
So for fiscal year '23, it was 45 million was what our contribution from both the GP and any grant-funded position. So that was the contribution in. So we haven't put any additional funds other than those that were built into our budget. But if, you know, looking at our '24 budget, if we don't, you know, we did plan on some cost mitigation because we were expecting to do the copay pharmacy changes. hoping to continue to draw utilization. So we figured that in when we figured the 25 budget, but we knew that's where we bumped to the 55 million, was putting more in from our salaries. But if we don't close the gap, we're gonna have to go dig into fund balance, look at some other ways to fund that while we look at the 25 budget. So part of this is also preparing for a 25 budget plan. So then if we don't, it's looking at in 25, what other decisions do we
catch
make
up.
to fund it?
Yeah, okay. Well, I'm like the others. When I was 20 years old, it's like, don't tell me about the benefits. I've got rent and a car payment. But this is a good plan, and the employees should very much appreciate it. And we've just got to market the insurance and the pharmacy. So I hope we'll do that. Thank you.
Ms. Black?
I know you said that it would take a significant amount of data, but I feel like we wouldn't be doing our due diligence if we didn't explore the state plans, and the potential cost savings to the district. I've been a state employee, the plans aren't bad. Especially when you have like 4 different options here. So the employees, so employees would still have a choice to work with to try and balance their needs versus their budget and stuff. But if there's potential cost savings by joining the state plan, I'd like to know what that is.
Okay.
We've got a lot more to get through. I don't know if we can kind of move through it.
We will try to rapid fire here. Brent, will you talk about the just dental insurance as well?
Yeah, so we talked about dental costs increasing, so just giving a scenario of ways to continue to drive some dollars on the dental. And this is basically just adjusting contributions. Instead of having a free option, there would be a cost associated with the base plan, and then also a increase in cost for the buyout, which would generate $1 million in savings as well. So another way to package, try to address the overall cost, and not have it all weigh on just the medical plan.
Okay. Penny, could you talk about retiree contributions to the board?
Sure. So retiree contributions also haven't changed. Now, please note that if an individual retires and has 15 years of service as a classified employee or 20 years as a certified employee, they continue to pay the same rates as employees. But we do have different tables based on when they retired and that type of thing. So we do need to reevaluate what retiree contributions look like, but make sure they're still affordable for them.
As we're talking about the different plans, we also talk about, change of behavior and, trying to educate our employees. And I'm going to ask Brent and Dave to talk about some things we're discussing going forward.
Yeah, so I'll give just the high level idea and let Dave talk, because the clinic would play a very big part of the wellness program and trying to drive incentives. And really the wellness program is targeted at ways to get people engaged in the health plan. One of the greatest drivers in healthcare costs are those that don't engage in the plan. They think they're healthy, and a year later, 18 months later, they show up in the ER and have significant health care because they didn't know they were sick. And those costs end up driving significant dollars that could have been avoided or minimized if they were just treated. So that's the prevention is a huge part of that, but also then managing conditions. I mean, those that have conditions, making sure they get what they need. And so the goal of the wellness plan is to make sure those resources are all available for the employees, their dependents to be able to access to get the best outcome as possible. Because the only way healthcare costs go down is improving health, decreasing risk. Because the cost of every good sold isn't going down. Like, it's going to continue to go up. And so you have to adjust the quantity that you purchase. The only way we adjust quantity is we drive better outcomes. We're healthier as a population. So Dave can speak. Let me give just parameters. That would be, there would have to make that effective, truly get people engaged, having some financial incentive in place. So you're earning a wellness credit of $100, including tobacco surcharge. So if you're using tobacco, you would actually pay more. unless you're willing to go through
So wellness surcharge or wellness credit?
surcharge. So it would be an additional. If you didn't, you would pay
If you
$100
don't
more
use
to
the
go.
services,
If you don't engage with a wellness plan and use our pharmacies and clinics or health coaching to try to combat those diseases, yeah.
Ms. Thurman, you had a question, sorry.
Yes, do they get to keep their own doctors with all of these plans?
Yes. Anything we've talked about doesn't change network access, who people are going to, none of that's
Unless
impacted.
we push toward the Park Ridge, if they had a Park Ridge doctor, they.
Right,
use
if they
those
made the
doctors.
choice to go to that, that's correct.
Okay.
Ms. Black.
Does the clinic function as like a PCP, or does it function as like an urgent care?
So we want to function as your PCP. We end up being both. But the important thing for us is that we want to get you into the clinic. Primary care as a whole is a small percentage of total spend. It's under 5% typically, but it's the mouthpiece to that next 70% of non-emergent care. And so to Brent's point on stuff like the wellness incentive, the more we can get you into the clinic, the more we can get your data, your blood work, the more we can prevent you from getting a chronic condition, or if you have a chronic condition, the better we can manage it. Or if you have some type of need for a specialist, either it's an ortho need or you need to go see a cardiologist, we're sending you at the appropriate time and we're sending you to the appropriate specialist, which in town we're very good at because we've been here for 10 years and Brent helped develop the specialist network we refer into across town. And so we can send you to better specialists, follow up with you afterwards, and then we aren't sending you to specialists when you don't need to go because you have access to care. And so what we want to be is access to care. And to your point earlier about the woes of a high deductible plan, I completely agree with you. It prevents access because the poorest among us think, I don't have the $150 to go at this point in time. But because you've offered the clinics and because we're 24/7, if you want to speak to one of our providers right now, you can. That gives people access without having to make a financial decision and save insurance for what it should be used for, catastrophic risk, instead of just taking care of yourself.
Hey, can Dave continue to talk about the just kind of the clinic's performance?
Yeah, absolutely. So if we're gonna actually impact cost savings, we've got to get people into the clinics. And so we launched at the start of COVID, and so in the beginning we had trouble. We launched, we closed them, and so what we've done here is just pulled total visit count and then eligibility. And so you'll see that we've had strong growth in total visits. The next slide will show you what those visits actually are, but we've gone from about 3,500 to 19,500 in 2022, and we're going to beat that this year. But we still have a lot more that we can bring into the clinic, and that's why a wellness incentive will help. On the second, engagement rate, so when we define engagement, that's total eligible lives, so it's dependent, we include dependents in that. The engagement of employees is actually pretty high. It's well above, I think it's maybe 70%. It's the dependents where we want to get them in. But so we're increasing engagement, we're increasing visits. What those visits are on this slide, the blue bars is 2021 and the green bar is 2022. The good news is that 85%, I would call it, is primary care and behavioral health. You see in 2021, we had almost 3,000 visits that were COVID. And we were worried about, okay, we're going to see a decrease in utilization because people aren't coming in for COVID anymore. And no, what happened is they were introduced to the clinics through COVID, and then now they continue to use them. And so introducing the clinics is important through new hire physicals, and we've worked with Penny and the full team on how to get people in on the front end. Because once we get in front of them, they realize the benefit. There's no out-of-pocket cost. We're sending them to the pharmacy. Again, there's no cost. They continue to use it. The final 2 points, one, I want to call out the usage of behavioral health. So y'all added behavioral health benefits through us, and they are extremely utilized. So last year there were 6,000 total visits, and when you think of from a benefit perspective, nobody else offers that. None of our clients reach that level of usage. It's unparalleled, and I can tell you your employees definitely appreciate the access to mental health services. And then why it's important, So in there, what we've done on the savings numbers is shown you just what for your patient, for your employees and dependents, what it costs for those with chronic conditions if they come to the clinic versus those that don't. And so you see net of our costs, the savings for diabetics is about $2,000 cheaper if they come to the clinic. And that number only goes up if we get more diabetics. The savings only go up because our costs are allocated.
We don't want to
to
get
them.
more diabetics.
Well,
No.
I agree with you, but the problem, there's two problems. One, you have a lot of diabetics that don't come because we're 41% utilization last year. And then you have a lot of diabetics that don't even know they're diabetic, and you have a lot of pre-diabetics that are about to be diabetic. And the more we can keep them from becoming diabetic, the better, especially when you look at the cost of the GLP-1 medications, I mean, that they will get on when they're type 2, when they become type 2 diabetics. Ultimately, the more we can save.
Thank you, Dave. And I'm going to let Josh jump in quickly just to give an overview of our utilization of our pharmacy. Josh.
Yeah, absolutely. So following with the clinic, they're at 41% utilization, and the pharmacy is currently at 40% utilization. So we derive that utilization number by looking at the total prescriptions filled in the network, and then equate it to what we call days of therapy. So you might have a prescription for a short-term antibiotic because you have an upper respiratory infection that's just a 5-day of therapy, but our pharmacy's filling 90-day supplies of those maintenance medications for your diabetics. So if we look at the days of therapy, we're capturing 40% of the entire claims, which is right in line with the clinic. 78% of our prescriber volume of your top 25 prescribers right now coming into the pharmacy come from our clinic. So if we can get a patient to the clinic, we can only get a patient to the pharmacy, and vice versa. We tell patients all the time in the pharmacy, yes, they can be your PCP. Yes, you can go have an x-ray at Hickson. So that lines right up. And to Dave's point about the diabetic spend, so 21 of your top 25 drugs spent at our pharmacy actually are diabetic medications. So a wellness program at the clinic plays right into the pharmacy utilization as well. Get your patients in there on a wellness program, and they come to the pharmacy and they have cheaper copays. Going through this slide though, the plan changes that they're proposing would actually create the same copays at the pharmacy. Right now there's 2 copay plans from Blue Cross and Cigna. The Cigna plan actually has $10 more on a brand name drug. Both plans have generics for free, no out-of-pocket cost. So they just simplify the plan for patients so we don't have to decide if you have Blue Cross or Cigna. It's just a clear communication plan. Here's your copays, 0, 10, or 20. And that's for 0s for generic, 10s for a preferred brand, and 20s for a non-preferred brand. So it's been alluded to, but that last line talks about the utilization. So we're currently sitting at the 40% utilization with a net return or savings of $3.9 million. So if we can double that, there's another $3.9 million on the table. We can just get 80% utilization. And that's going to be done through plan design. We've had a very robust communication strategy from the time we opened from COVID. I mean, from getting into schools, going to principals meetings, secretaries meetings, flyers. I've been in commercials. I had somebody come in the other day and she goes, "Have I seen you in a commercial?" And I was like, "You probably have." So, it's all about that behavior change, and the behavior change comes from a plan design. So if we give them incentives, so if you'll go to the next slide here, this really shows it.
I'm gonna pause you for a
Absolutely.
second. I do have a couple comments, Ms. Thurman.
I didn't want, that was for something else, but go ahead, let him finish with the
Okay.
pharmacy. I'm sorry, I'll clear that off. I'll answer the question later.
So this next slide looks at the member share versus the plan share at the pharmacy. So this is a total drug spend from July of 2022 through June of 2023. So this is the last data report that we just gave. You can see your total drug spend was at about $27.9 million for every claim, no matter if they filled it at a network pharmacy, which is CVS, Target, Walmart, or they came to us. Your members only picked up $844,000 worth of copays, which is just a 3% member share. So on average, your member copays were about $3. And some of these drugs are $6,000, $18,000. As he alluded to, the diabetic drugs, all the GLP-1 drugs, which are the new injectable drugs that everybody's seen on TV, Ozempic, Mounjaro, Trulicity, they average about $900 for a month's supply, and your average copays are $3. So it goes to say again, the robust plan, but we have the cost savings benefit. Like I said, if we can double that utilization, there's another $3.9 million. Paying attention, so it takes about $4 million for a 1% raise. We just need to get some utilization, and there's a lot of money to be made up there on that $10 million too that we're trying to get to. The next slide, we'll talk about the pharmacy recommendations. So this is, and Brent, you can chime in too, but this would be the proposed copay changes. So if you look at the far right, you can see that the Ed Health pharmacy copays are not going to change, other than they're going to simplify it and make it one plan. So still going to be 0, 10, and 20, but you can look at it in the network as well. For generics, it'll be a $20 copay. For preferred brands, it'll be $45. For non-preferred and specialty drugs, it'll be a $65 copay. So this is what's going to drive that behavior and change the patient's mentality to use the pharmacy. And we've already got the stuff in place with mail order, 2 locations. To give you some comparison, some of our other clients have achieved 80 to 85% utilization. They have less hours than we do. They're not open on Saturday. They have 1 location and they don't do mail order. And they're still achieving 80% utilization, but it's due to plan design. So that's where these proposals come from that they've looked at. And the last thing is something else that the patients can save on. Once we get them in the pharmacy, a lot of people, the best thing they like about it is they can buy over-the-counter medications at cost. So this is a cost comparison I put together. You can see what it costs for certain medications at our Ed Health pharmacy. There's a little disclaimer that those can change at any time due to, we sell everything at cost. It's a pass-through. There's no markup. So when I buy a bottle of Zyrtec for $6.19, that's what the patient pays for it. If you just Google right now about the cheapest you can find at a big box store without it being buy one, get one free is $22.99. So the member's going to save on their copays, but then they're also going to be like, oh, I didn't know I could get my Tylenol.
Can they
my
order
Band-Aids,
these
my
mail order, or does this all have to be at the pharmacy?
This has been picked up at the pharmacy. We have not opened up an over-the-counter, like we don't have a website or anything for them to be able to place orders on that. So it's just been for prescriptions, because as you get larger packages of OTCs, then the shipping becomes a lot more expensive. So that's just another benefit. So once we get the patient in the door and they save money on their copays, they're also going to save money on their over-the-counter medicines. And we have a robust selection of anywhere from multivitamins, single vitamins, cough cold products, first aid kits, sunscreens, deodorants. So there's cost savings there for the patient to kind of mitigate some increased costs with the plan. Any questions regarding the pharmacy or utilization? I have tons of data too on any drugs. If anybody has questions, feel free to ask them.
So, thank you all. Thank you for, again, this is a lot of work, and benefits is always a lot of work, and there's no way to get around it. As far as next steps, I obviously, the board can speak to it. My concern of changing to like a state and all the work that it takes to do that research is that you don't just change plan, but some of people don't find out what they lose till they go, and then all of a sudden that's not there. And we know that what we have right now, nobody questions is top of the line. Like, we have as good as you can get. The problem is, as we've all said, it's not sustainable at the rate at which we're going. And I agree 100% with Ms. Black in that we don't want to say, here's a raise, we're going to take it back, right? Like, it's this balance of we have to create sustainability long-term, where we're not waiting 10 years every time to make a change. It has to be gradual. I think I've said this every chance I can, the pharmacy and the services that we have available are excellent, and so for me, it's been excellent. I've used even it hasn't, it's not on them, it's on me, but the nutritionist to try to get some things in order. Like, there's a lot that we're making available, and for me, what's hard is if we don't, here we're providing this, but people choose the most expensive pathway. It's hard for me to understand why we are always taking the hit on the most expensive pathway.
Yeah.
So
Can I-
there's lots
can I
to do.
just-
Yes, Ms.
okay,
Turner.
well, a
please.
couple of things. Do they have doctors in these clinics? Are they nurse practitioners? Are they, what are they?
Nurse practitioners and PAs overseen by physicians.
Okay. Another thing, I remember a few years ago, we started a health plan for the the low-income people in the cafeterias and things like that. Did we not do something like that a few years ago?
So all of our employees, the part-time employees, school nutrition, all of them have access to the clinics.
Okay, that's what I was gonna ask.
Yes, ma'am.
They do all have that. I think that they need to be made aware of that.
Yes, ma'am.
I think that.
And
that's
to the
fine.
pharmacy as well,
And to the
right?
pharmacy.
If they go to the clinic to be seen and they get a prescription from the clinic, then they can have it filled at
But
the
even if they
pharmacy.
don't have the insurance, correct, they can do
Right.
that. Well, I think that's something that we need to.
And they're using it. We actually we
Okay.
did this for Penny to check on-plan, off-plan utilization, and that 40% is broadly the same across both groups. The off-plan are using it right now.
Okay, but didn't we start a healthcare plan for those people? Am I not remembering that correctly?
We didn't start a specific healthcare plan. We just
Okay.
opened up the clinics, and we started it during COVID because I opened it up so that they would have access to telehealth, and then we've since opened it up to allowing them to come into the clinics for healthcare as well.
And I noticed that, by the way, in that our increase of the cost of the clinic, which has also gone, but we made that shift where we opened that to everybody, but we didn't see this like exponential increase on the clinic cost. So that's obviously showing results. This way.
I know you mentioned that you wanted to get more dependents into the clinics. Do you have pediatricians as well as adult
We,
practitioners?
So we will see kids down to 2. The reason we don't see under 2 is because of vaccines. We don't care. They've got a special, and so yes, we will see kids. They're not we don't want to be your pediatrician, but for most of the reasons that you would want to, I've got 4 kids, and I actually don't have a pediatrician. Our founder, Keith Helton, is our pediatrician, and also treats your employees as well. But for most of the reasons, absent special cases, of course, the stuff that like keeps you up in the middle of the night or wakes you up or you go into urgent care with your kids, we can absolutely treat.
Earaches, pink eye,
Absolutely,
sinus
all day, every day.
all the things.
Yeah.
Sports physicals, you know,
Yeah.
those things are,
Okay.
yep.
All right, I'm trying in my head, so the wisdom of others is great here, to try to figure out what the next step is for us as a board. In my opinion, you've done a lot of work. Thank you for presenting us. Again, the purpose of this is to present it publicly so that we can have the conversation publicly, but also for us to realize that what we have isn't sustainable, and we need to come up with a formula that works.
Martha, we don't need the people to get angry with us. This is the healthcare.
This is exactly.
This is not us.
This is the system for everybody on the
Everybody,
planet.
yes.
And anybody, if you've used our system and our healthcare, and some of the plans, and you know anybody in the country, you sit there and you say, oh, this is amazing. Like, this really has served. I don't want to pretend that that's true for everybody. I don't know, but for a lot of people, that's what they've seen. So, I think we've got to chew on this. If we need to have either an earlier work session or another work session, then we'll call for it. But for at least the next week, because we will be presented on something to vote on the 21st when we get together. And so I'll communicate with the staff, and if we've got to call people back. But in the meantime, please communicate with the team to discuss any additional questions.
And Chairman Perez, we are available to meet individually at any time. Just contact me. I'll make sure that we have a team together. We want to make sure you're well informed. Know this is a heavy lift, and we'll get the information you requested as well, Ms. Black.
What's an open enrollment period? When does that begin?
It'll be October 6th through October the 31st. So
Yeah.
we definitely need a decision on the 21st. And we need to know a little bit sooner which way we're leaning, because we do have to go ahead and start loading everything into the computer so that elections are ready to be made for employees on the 6th.
I'll tell you, from my perspective, the one thing, $100 tobacco, that's whatever. It's a reality, and people, punishing them on a monthly basis may be necessary. I think the wellness one, $100 a month. I don't quite understand what you mean by, well, are they using it? Does it mean if they do their once a year visit, that's it? They save $100 a month if they went once a year?
So we can ultimately design, it can be any of all of the above. I'll give you an example. For Sumner County Board of Education and the county government, they have a plan where it's about 100. What they did was they kept their current plan, which is very rich, not as rich, but very rich. And they named that the wellness plan, and then they created another one which was about $100 more a month, and they said this is now the normal plan, and in order to qualify for the wellness plan, you just have to come get, it's a health risk assessment, which is blood work, and it will take your blood pressure, but a very basic mini physical. And then if there are, if you trigger on high cholesterol, any
Yeah, take the
A1C's high,
medicine.
then we're going to put you in a health coach and want to see you again. But they're very minor. We try to make it as painless as possible. What we really want is you to come to the clinic. We want to get your blood work. And their utilization is 97% because it's a huge financial benefit for them to come.
And it wouldn't actually start until 2025. So 2024 would be that planning year to get employees engaged in their wellness activities, get their physical, and then if they haven't engaged, then in 2025 they would see that premium change.
Yeah, and that's the thing is so anyways, we have a lot to chew on. We may, if the board wants to review. For me, I think your proposal, which one is it, where we've got deductibles going out, like everybody on the planet has deductibles going up, where some of the cost of some of the treatments, like some of that makes sense, but I don't know the rest of the board where they'll link. So maybe you can check in on board members after you've reviewed this, but thank you. Any other comments, questions? Thank you for your work. This isn't easy work. This is really hard work. And I agree with Ms. Thurman. We don't manage